the topic of lacrimal system, the lids and orbit, the common ophthalmic topics in the ophthalmic clinic as well as in the general practitioner clinic. We have some problem with the direct presentation from the laptop, so we are going to actually run two different lectures on diverse field. In spite of best effort, this can happen. Now, the aims and objective of this presentation, which include these three subjects, is to learn common causes. The participant should be able to learn common causes of exophthalmos and other orbital disorder, and to refer them when needed, diagnose lid an excellent problem in the GP clinic, and to recognize the causes of epiphora in infancy and dactyocystitis. The outline of presentation is like, first the orbit is to be presented, followed by the diseases of the lid, and then followed by the diseases of the lacrimal system. Now, let me give you a little bit of anatomy. Of course, we have read anatomy in the early days, but this is just to refresh. There are 85 openings, and all the important openings are in the front involving the orbit. There are 22 bones divided in the cranial and facial bones. Now, we are concerned with the orbit, and the orbit are placed anteriorly in the upper part of the skull. Two orbit directing anterolaterally with the medial wall in the central plane, and has got four major opening. One is the anterior opening through which the eyeball is coming out, and the second is the optic canal and the two orbital fissure. You can read or see here. Now, around the orbit there are sinuses. Now, sinus disease is very common. For one reason or the other, this sinus disease is increasing day by day, and they are very intimately and closely related to the orbit. So, sinus disease can affect the orbit, and there are four sinuses, as you can see, the frontal, the ethmoid, sphenoid, and the maxillary sinus. Now, at times the sinus disease could be presented as orbital disease. The common orbital inflammation that we see in the clinical practice are pre-septal cellulitis or orbital cellulitis. Now, there is an orbital septum which separates the structure in front of the orbital septum from the structure behind the orbital septum, the true content of the orbit. Now, pre-septal cellulitis could be due to insect bite, or could be a part of the orbital cellulitis extension anteriorly, or some lid associated pathologies. Now, there is a pre-septal cellulitis. Now, it is very important to differentiate the pre-septal cellulitis from orbital cellulitis. Now, this is a pre-septal cellulitis, and the important feature is that the eyeball is normal. The eyeball looks quite healthy. You can see there is no conjunctival congestion. We don't see any bulging of the eyeball, which is called proptosis. The swelling is well localized anterior to the eyeball. Now, as compared to pre-septal cellulitis, the second important entity that we come across in the clinical practice is the orbital cellulitis. Now, this is a condition in which the inflammation or infection is within the orbit, and the commonest source of this infection is one of the sinus. Ethmoid in children and maxillary in adult. This is the normal way of presentation. Ethmoid has got a very, very thin wall, so that's the reason inflammation within the ethmoid can enter into the orbit very easily. Now, as compared to the last picture, you can see that the eyeball is bulging forward, which is seen from the front as well. You can see the conjunctival congestion. You can see the tension or swelling is also not limited to the lids, but it has moved to the nasal side as well and has spread inferiorly. Now that's the orbital cellulitis. Now in examination in orbital cellulitis, there could be impaired ocular motility. Now it's an important sign because that shows the involvement of the muscles. There could be pain, proptosis, as we have seen in the earlier picture, decreased vision, and in advanced cases, afferent pupillary defect, disc edema, and so on and so forth. But of course, at your level, it's important to diagnose preseptal and to differentiate it from the orbital cellulitis. Orbital cellulitis has to be referred as early as possible because it's one of the ocular emergency. Preseptal can be treated at your level and does not require too much of medication. Now that's the advanced stage of orbital cellulitis. You can see that both the eyes and the lids are involved, and the eye wall due to edema is totally, the eyelids are totally closed. Another bilateral orbital cellulitis, you can see the extent of swelling and closure of the lids. Now the danger with bilateral orbital cellulitis is that extension can go into the brain, into the cavernous sinus. That's a very potentially lethal condition, and it should be treated with vigorous means. Now during the clinical work, I don't need to go into the detail, but the local signs of inflammation and muscle restriction, proptosis are the three more common features that we see in orbital cellulitis. Now this is one of the sinus bulging into the orbit and has pushed the eyeball laterally and outward. Now that's the plane of the normal anterior limit of the eyeball, and you can see that this amount, this is the eyeball which is pushed forward, and the lesion is in one of the sinus. The investigations includes blood cultures, orbital CT now available, but affordability of course is a problem. A simple X-ray can give a good sinus view, and can help you in making a diagnosis. Another picture, you can see that there is the sinus here, and it has pushed the eyeball laterally and forward. You can see the plane of this CT is showing that the other side you don't see the eyeball, which means that the plane is a quite front plane that was selected during the CT scan. The treatment is hospitalization, IV antibiotics. Very important because that's the only treatment that can help and save the patient. And surgical drainage, of course, is not. The complication could be important is cavernous sinus thrombosis. That is one complication which can lead to that's a potentially fatal condition. So a proper diagnosis of this should be made in time in order to save the patient condition. Now what are the signs of cavernous sinus thrombosis? Bilaterality, both orbit involved, rapidly progressing deteriorating condition of the patient, and level of consciousness. So these are the three signs with the help of which we can make a diagnosis of cavernous sinus thrombosis. Now thyroid eye disease, a common feature in our outdoor, has got number of names. You can read here: thyroid eye disease, Graves, ophthalmopathy, thyroid associated, so and so forth. Now the presentation of thyroid eye disease is that it's a gradual, slowly progressive bilateral proptosis, number one, and number two, restricted ocular movement. It is because that the muscles of the eye, they are swollen and they are restricted, and patient may present in the early stage with a painful ocular movement in all gaze, dry eye itching, and difficulty wearing contact lens because the eyeballs are proptosed to the extent that they are very rapidly dried out due to infrequent blinking of the eyelid. There could be inflammation. I am going to show the picture in the next couple of slides. This is a thyroid eye disease. The conjunctiva is not inflamed. The lid still is closing properly during sleep or during the daytime, but there is asymmetry between the two eyes, and you can see it's a bilateral proptosis due to thyroid eye disease, more or less same on two sides. In advanced stage of thyroid eye disease, due to constant exposure or proptosis of the eyeball, the conjunctiva it becomes more keratinized like skin, and it is, you can see the chemosis, roughened conjunctiva, and a persistent bulging upper and lower lid area. You can see the signs of chronic inflammation in the conjunctiva as well. Now, it can lead to chemosis, double vision or diplopia. Once the muscles are not functioning properly, there is restriction of the eyeball movement leading to diplopia, double vision. Thyroid eye disease has a tendency for remission and recurrence, so it needs to be observed very closely. Now, diagnosis is made on typical feature. Most of the diagnosis is a very easy diagnosis and is based on clinical findings. Although some support from the lab and the imaging technique, muscles evaluation, muscles density, thickness can easily be measured in orbital special slices, orbital CT or MRI, and there are serological tests like race T3, T4, TSH, thyroid auto antibodies and stimulating antibody. But fortunately or unfortunately, the thyroid serological tests at times are not very conclusive. So, it is the typical ocular feature which is the key to make a diagnosis of thyroid eye disease or with the help of orbital CT. Now, here there is a CT scan. You can see a very thickened large muscles, all the both the muscle lateral and the medial recti, but medial rectus being more swollen as compared to the lateral rectus on this side as well as on the other side, and this is the optic nerve, this is the eyeball. Now, this is another view. This is a coronal view. You can see this is the optic nerve, and all the four muscles are grossly swollen, including the levator palpebrae superioris as well. So, this is the typical feature, CT scan feature of thyroid eye disease. You can see that the muscles are swollen here, and the nerve is also decompensated and swollen due to chronic function disorder. The management is exposure. We have to actually prevent the eyes from exposure. Now, another feature of the thyroid eye disease is the blinking rate reduces. There is a lid lag, the lid closes and opens very slowly. So, they all lead to dryness of the eye. So, we can give something to cover the dry part of the eye, the dryness of the eye, by giving the patient some lubricating drops or some ointment or gel that are available, and prevent the eye from exposure. And exposure keratopathy can lead to opacity of the cornea and permanent visual disability. The diplopia can be corrected in a number of ways, mainly surgery, and these are the surgical options that are available for thyroid eye disease. Now, this is a thyroid eye disease before and now after surgery. Now, what has happened? The eyeball is not touched here. It's just that the aperture are made smaller. The opening eye aperture. This picture gives a very staring look, and once there was reconstruction of the lids of upper and lower, it becomes a little normal. On the other side of the picture, there is some convergent element because of the muscular involvement, and with the lid reconstruction as well as the squint surgery, the eye looks more normal here. Now, a little bit on the orbital tumor, not frequently, but of course one get these orbital tumor in the clinical practice. There could be developmental anomaly or cyst or a dermite. Vascular tumor are very common that we see in our small children. these tumor, they grow out with age. By the age 8 to 10 years, these small vascular tumor, they disappear. There could be lacrimal gland tumor, meningioma, and other tumor. Now, important among all the lacrimal, the orbital tumor that we see in the clinical practice, capillary and cavernous hemangioma is very, very common. It accounts to about 70 to 80% of presentation in the outdoor. Capillary is something which is in the childhood, in infant and children, and cavernous at the later stage of the in adulthood or in the middle age. There is a capillary hemangioma along the distribution of the nerve. It's not restricted to the skin, but you can see that the extension is within the orbit, and it has pushed the eyeball a little, inferiorly as compared to the other eye. This is a cavernous hemangioma. Now, cavernous hemangioma normally present behind the eyeball, behind the globe. So, they generally push the eyeball centrally. It does not eccentrically shift the eyeball, it pushes the eye centrally, generally centrally. You can see that this is the cavernous hemangioma, it has pushed the eyeball forward. Now, due to further extension, the eye can be moved up or down or whatever, but generally it is one of the cause of axial proptosis. Dermite cyst, very common. It's a painless small swelling around the eye, and the commonest area is around the eyebrow area, and it responds very well to surgical treatment unless it is extended internally, intracranially. Rare tumor, rhabdomyosarcoma is a rare tumor. It's a very, very difficult tumor to treat, and the overall survival rate is very, very low with this tumor. It spreads very in the early stage of the disease, and by the time the diagnosis is made, it has spread all over the body. So, the treatment, of course, is not surgery, it's one of the chemotherapy. Now, I'll just touch the lids, and just to give you an anatomy of the lid. This is the posterior lamella, which has the meibomian gland over here. These are the duct of the meibomian gland. That's the gray line, the junction between the two, and this is the anterior lamella. Sweat gland, gland of Zeiss, different glands, and the lashes root are located in the anterior lamella. Now, amongst the eyelid condition, the commonest problem that we see in the clinical practice, and I'm sure you also this as a commonest eyelid condition, is a blephritis. Unfortunately, it's overlooked. Most of the time, we don't concentrate on the lashes and the diagnosis is missed. So, we look into the other difficult areas of the eye and the lid, and something which is very obvious is and very easily treatable condition is often missed, and a patient go home with the symptom that he or she had come with. Now, this is a normal lash root area. Now, this is the blephritis. You can see some scales at the root of the lashes. These are the scale and the debris like the scalp dandruff. The sign and symptoms include sandy, itchy eyes, red, swollen eyelids in advanced stages, crusty. The reason for itchiness is that these scales, they get inside the eye, in the conjunctival sac and on the cornea, and they initiate rubbing. Once the patient is rubbing it, it initiates a vicious cycle which further aggravate the situation. Now, this is the early stage of blephritis, what we call the squamous blephritis, in which the roots are studded with scales. It is treatable, very easily treatable. It needs a proper hygiene of the lashes. It needs something to be which can keep the eyelashes wet, oily, moist all the time, and it requires some antibiotic if there is sign of inflammation. Now, this condition, blephritis, actually it relapse and it go into relapse and remission. So, if you control the relapse stage, and you don't have to worry about the remission part, because it comes and goes throughout the year, like a month of illness, and then a month better, and then again. So in advanced stages, we see that the dryness is the lashes, along with the dryness of the lashes, you can see that there is crusting or ulceration of the skin or skin break at the lid margin. That's very painful and very difficult to treat. And you can see another advanced stage of the blephritis. You can see that the blood oozing out from different areas, and it requires very vigorous treatment. As I mentioned earlier that lid hygiene proper. Now it's very simple. If you ask the patient to, when washing face, just rub the lashes as well with the soap, and then dab it or dry it with some towel or tissue paper, and put some Vaseline, petroleum jelly, or anything oily over the lash root, and that's it. And if there is some sign of inflammation, a weak steroid, a combination steroid like betnisol and eye ointment with the antibiotic for a week or so should be sufficient. The important thing is, I am very against using steroid in the eyes unless it is indicated. But with the betnisol eye ointment, you can rub the eye, tell the patient to rub the ointment over the lash root and not let the ointment go inside the eye. That's the key. नहीं. पीछे आ जाओ. Okay. Now sty is another common presentation in the outdoor clinic. Is the inflammation of the lash root. If you go to the anatomy, is the infection of the lash root, which actually the bacteria is normally there, but due to some reason, due to low immunity or whatever, the bacteria start growing at the root of the lash, and it is presented like a small yellow pimple at the lash root area. You can see a couple of styes. Now they are limited to the lash only, but once they start swelling, one can see the sty is a large swelling which could be very painful. It's a small compartment. Any swelling in that area could be very, very painful, as is true with the small compartment swelling. Now Chalazion, if you go just to remind you the anatomy, the first slide of lid, on the posterior lamella there were meibomian glands. So these meibomian glands, they secrete fatty secretion. Now Chalazion is the swelling of these meibomian glands. Now these meibomian glands, when the duct is closed, they swell, and they swell like a small pea-sized size swelling, and most of the time it is not infective. So it is a disfigurement that patient will come with, not with the pain or inflammation. Rarely Chalazion can present as inflammatory swelling, but generally it is a painless disfigurement that is the mode of presentation. Now you can see that there is no sign of inflammation over the skin. You don't see any sign of inflammation within the eye. It's just a swelling. Now what this swelling can lead to, agar ye yahan hai to can anybody think of any effect this swelling can lead to? There is no infection, there is no threat. It's a small swelling in the upper lid area. Ji? It can lead to corneal ulcer. Your first part of the answer is correct. It can create pressure, not on the lacrimal duct or whatever, on the eye wall. If you just push your eye a little bit, you see everything is blurred because of the corneal curvature, which is deformed because of the pressure. A similar swelling right on the cornea can deform the vision, can give a high cylindrical deficiency, and it can cause visual deterioration. And secondly, of course, cosmetic disfigurement. For these two reasons, we advise these cysts to be removed. Now that's the infected Chalazion. It has burst out. You can see the inflammation. You can see the opening, possible opening here, and that self-sealing stage. But it has actually closed the eye, and it is so I think we've already asked a question in the middle of presentation, because there's a way to keep everybody active. Now there are a couple of very minor ailment with which patient can present, and it's very easy even in your clinic to just take care of these problems, like a lashes turning inside, and the patient would present with constant irritation, something rubbing in the eye. The general presentation is upper lid presentation is the patient would say that there is some irritation in the upper area, especially when blinking. And in the lower lid trichiasis or misdirected lash, there would be irritation in the lower eye area. So when one or two lashes are turning inside and they are constantly rubbing the eye, it is called trichiasis. And when there is a row of abnormal lashes all turning inside, all rubbing the cornea, it is called distichiasis. You can see that the lashes are now once you remove the lash, in 6 weeks time it will come back, because the root is there, and the root has a tendency to form a new lash, the direction of which would be the same as the previous one. Now what we do in such cases, we try to burn the root of the lash, but of course for temporary relief, if you can remove the lash, it will take care of the symptom that the patient has presented with. Next. You can see a lash rubbing the cornea. Very sorry to giving lecture in such a good weather. Now entropion, I'll just touch the entropion when the lower lid is or upper lid as a whole turn inside, that is entropion, and ectropion when the lower lid or upper lid has turned out, that is ectropion. Now that is an entropion. It is generally involutional, old age, when there is discrepancy between the function of the muscles. One portion of the muscle is not functioning properly, the other one is doing over, then it is it has turned the lower lid inside. And a very simple method of treatment is, temporary treatment is, just pull the lid and put some adhesive tape. So that's a quick method of treating the entropion. Now that's a congenital entropion. Ectropion I've already mentioned. That's the ectropion, that's the entropion. That's another example of the involutional age-related ectropion. Now it is not like entropion is causing irritation to the cornea, watering and discomfort. Ectropion doesn't cause any problem with the cornea. The problem that it causes is epiphora, or water coming out of the eye, because water is generally secreted here. It travels through the lower lid, by about 70% travel through the lower lid, 30% through the upper, and then from the punctum it goes into the nose. So there is problem with the ascent of water, so it trickles down right from the middle of the lower lid. In chronic exposure of conjunctiva, chronic exposure of cornea can lead to keratinization. These tissue becoming more of skin. Ptosis is a drooping of the upper eyelid. Are you getting it? There is no need to it. The thing is, you should be able to pick up ptosis. Now, important thing about ptosis, generally ptosis are congenital. Generally congenital. Advanced stage, late stage ptosis are secondary to some disease. And the commonest disease is myasthenia gravis. Congenital ptosis should be treated for the reason that that's the time when the vision is being in the process of development. If for some reason the input is not there till 5 years of age, there is permanent visual deterioration that the individual has to follow throughout his life. These are very important parameters. There are 3 important parameters. Number 1 is 18 months. number 2 is 5 years, and then 8 years. Majority of vision develops within 18 months. Whatever left then is developed till 5 years of age, and then a little bit of final coordination is completed by the age 8 years. After that, nothing can be done. Now, let me give you an example of amblyopia. Amblyopia is a condition in one of the eye is weaker eye, and at times diagnosis is made at the age of 60 years. Why? The reason is that it was not properly checked in time. Now, for amblyopia, there are treatment available, and because of the treatment, an amblyopic eye can enjoy a very good normal vision if properly treated before the age of 8 years. Now, after that, nothing is possible. So similarly, if there is a ptosis, there is a drooping of eyelid, which means that the input is not going inside the eye, and if nothing is done for the ptosis, and the child has passed the age of 8 years or so, that eye would remain lazy or amblyopic for the rest of the life. The best thing is to temporarily improve or reduce the ptosis, or to refer them to the concerned specialist for proper management. So ptosis is important for, as I mentioned earlier, this is because of out of the ptosis, 85% to 90% of ptosis are childhood ptosis, early stage ptosis. Yes, please. The important thing is, the examination of the eye from your point of view should involve checking up of the visual status and eyeball condition when you're sitting at the level of the patient. Now, it's very important. Don't please check the patient when the patient is sitting and you are standing, or patient is standing and you are sitting. It should be one level. And when you and the patient are at one level, see if the pupillary areas are clear in normal situation or condition or not. If the pupillary areas are clear, it means that the vision is, if not normal, it is close to normal in the process of development. If the pupil area is close in primary position, that is the case, needs a proper refer in time, so that the vision should be improved with whatever means that we have.
I have no idea what you would do about the ptosis. You say in one or two words.
The management of ptosis in congenital ptosis is a surgical management. So you don't have to do anything. It is either we resect the muscle, shorten the muscle, which elevate the upper lid, or we do some sling or supportive procedure like sling operation. If the levator function is very poor, we just have to lift. So then the child, in due course of time, learn how to open the eye and the close. They have to learn after the surgery. They have to learn to close the eye. Now, we have opened the eye. It is the problem with the closure. And the closure, when do you need closure? You need closure when child is sleeping. That's the time you don't want the eye to be open. So the procedure is always done under correctly. It's always under corrected, because we don't want to do overdo. We don't want to over open or excessively open the eye, because that will lead to exposure problem and corneal ulcer, etc. What was?
I had MBBS with ptosis. But now, last year I was operated. Dr. Imran associate.
So what is your problem with the glasses?
Yes, पहले नहीं यूज़ करता था. उसके बाद यूज़ किए हैं, तो वो सिलेंड्रिकल हैं और वो बहुत सारे प्रॉब्लम था.
देखिए बिल्कुल बैठो जी. ऑपरेशन जो अब इन्होंने जो कि मेंशन किया, एक मिनट आएंगे ज़रा. दिस इज अ स्लिंग ऑपरेशन.
जी, ये फेशियल लेटा लिया था मैंने.
Sling operation, you can see the cut mark here. It's a kind of a rectangle with a dome is made like this. and the upper lid area is then hooked on with the, we can take a facial latta, we can take some Marceline mesh, we can take some Proline or whatever. Now it, you know, it has to be developed. I think your correction is very, you know, it's quite accurate correction. We don't want to overdo it, because that will lead to exposure keratopathy. No? Overdo mean exposure in the primary position like this, and a closure of eye to the maximum like this while sleep. So underdone hua, I think. Now regarding the, your problem with the glasses, lashes has got tremendous weight effect on the eye. Now just to give you an example, just push the eye a little and see everything is blurred. It's because the corneal curvatures have changed. Because of the facial latta, because of the suture, because of the disproportionate weight transfer of the upper lid onto the cornea, this number has come up. But of course you have to live with it.
We could also ask him when he got the operation done.
19th September last year.
So ideally it should have been done before the age of 19?
It should be done before the age of 10. Rather. Or before the age of 15 or 16 years.
उससे सर एक और प्रॉब्लम मेरे साथ ये हुआ कि पहले मैं
स्कूल गोइंग एज में जब जाते हैं ना बच्चे, या जब प्रैक्टिकल लाइफ में जाते हैं, या बच्चों की जो शादियां हो रही होती हैं, तो कोशिश करते हैं उससे पहले हो जाए।
ये अब 10-15 मिनट के बाद जो मैं मसाज करता हूँ, फिर इतना प्रॉब्लम हो जाता है देखने के, मैं देख नहीं सकता।
आपको कितना प्रॉब्लम पहले था और कितना
उससे बहुत ज़्यादा बढ़ गया है, मैं ये कहूँगा ऑपरेशन के बाद। पहले तो डिस्कशन से मैं जब मेडिकल कॉलेज में थे, 8-10 दोस्त जाते लाइब्रेरी में पढ़ के आते थे, मैं बाहर उनसे पूछ पाछ के कर लेता था, पास करके एग्ज़ाम। अब मैं पढ़ने के चक्कर में जो पढ़ा हूँ ना थोड़ा बहुत, उससे ज़्यादा प्रॉब्लम बन गई।
एक तो आप आगे बैठा करें थोड़ा सा। Of course you have to, you know, it's variable in different gaze. It is one of the effect of you know, these prostheses that we use during sling surgery. But इसका solution ये है कि इसको कट करवा दें और back to original. Okay. I am concerned as an ophthalmologist, I am concerned whether pupil is clear or not. If the pupil is clear, no matter how bad or good the amount of ptosis is, I expect a normal visual deterioration. The reason, may I ask your name, sir? Your name, sir? Dr. Badar. The reason you did not enter into the state of amblyopia was you had a bilateral ptosis, and you always in the past had been correcting your ptosis with the help of head tilt. Am I right? So anyhow, since I don't know, if I had seen you about a year ago, I would have, you know, advised you not to undergo any kind of surgery. तो आज थोड़ा सा कर लेते हैं. Average age is don't be disheartened. Now generally, if you see the fold here, this fold actually is a diagnostic feature between congenital ptosis and an acquired ptosis. It is not present in congenital ptosis क्योंकि ये मसल कभी फंक्शन ही नहीं किया होता, इसलिए फोल्ड ही नहीं बनता. तो in acquired ptosis the fold is always there. That's a very important diagnostic point. Now what we do is a broad suspension, as with your case, or tarsoconjunctival resection. Levator resection or shortening procedure is done when the function of levator muscle is normal, which is not usually there in congenital ptosis. Now a quick word on the lid tumor, benign tumor, melanocytic, vascular, granuloma and viral wart. You can see a vascular tumor in the lid area, another vascular tumor in the upper lid. In the malignant variety, basal cell, squamous, sebaceous cells, carcinoma and melanoma are very common. This is the rodent ulcer, a small and a large encroaching the medial angle. There is another nodular basal cell carcinoma, and this is the sebaceous gland tumor. Now conjunctival melanosis is very common. But the important thing is whether it's normal or abnormal. It's very easy to diagnose if you just draw or measure the extent of lesion on the paper and re-examine or re-measure after 3 months or 2 months. If it is enlarging, it is something which is not good. A quick word on the lacrimal system. This is the lacrimal gland. These are the two punctum, two canaliculi, a common canaliculi and a lacrimal sac and the nasolacrimal duct. Now important thing is during the basal secretion of the eye tear secretion, it is not the lacrimal gland which is responsible, it is the accessory lacrimal gland which causes the normal wetting of the eye. So what is the function of lacrimal gland then? What is the function of lacrimal gland? If the normal secretion is the normal basal secretion in 24 hours is the responsibility of the accessory glands, not the lacrimal gland. Then what is the function of lacrimal gland? ये यही है कि बस डिजीज़ हो जाती है इसमें और स्वेलिंग हो जाती है. वो तो एक्सेसरी ग्लैंड का फीचर भी है. इसका रोल है इन इमोशंस, फॉरेन बॉडी, क्राइंग. कितना इम्पोर्टेंट रोल है. नेक्स्ट. नाउ मे आई आस्क व्हाट इज द डिफरेंस बिटवीन लैक्रिमेशन एंड एपिफोरा? There is a difference between epiphora and lacrimation. Lacrimation is when the drainage channel are normal and there is overproduction of tears. Overproduction. And epiphora is when the drainage channels are not normal, obstructed, narrowed, and even a normal secretion is coming out of the eye. That's the difference. Patient complains that they are watering, eye is watering. But when you examine the patient eye, you don't see water coming out of the eye. The normal, there has to be a normal limit of normal wetting of eye with the tear. If it is slightly more than that, but not significant enough to be coming out of the eye, that is the patient normally complains कि जी eye गीली रहती है या आँख गीला रहता है, but it's nothing is coming out of the eye. You can see that nothing is coming out, but you can see a small droplet in the middle of the lower lid. Now what are the diagnostic tests? A very easy diagnosis that you can learn, do in your clinical clinics is to differentiate epiphora from lacrimation is if you put a drop of some eye drops, antibiotic or whatever, into the conjunctival sac in one eye and ask the patient if they can taste something at the back of the throat after 2-3 minutes or 4 minutes, it means that the system is patent. Now आप किस चीज़ से करेंगे? Now very common drops is जी very good. Why chlorphenicol? It has got a bitter taste. लेकिन आप उसे किस तरह realize कराएंगे? What I do is I put a little drop on that little finger and ask the patient to taste. Taste करने के बाद कि it's a bitter taste, and then put the drop in one eye, not in two eye, फिर पता नहीं चलेगा. One eye, and I ask the patient to sit quietly for about 5 minutes. Patient would come up if the system is patent that they feel some bitter taste at the back. Now once that is all right, you do the other eye. So with this a simple test, you can easily differentiate which is epiphora and which is lacrimation, because the management of two is different. Probing and syringing we do in children. Dactyocystography, lacrimal, that's not required here. Congenital anomaly can involve one of the structure. Lacrimal congenital epiphora, a common presentation. A patient presents before the age of 6 months or a year that the child is constantly throwing water of the eye, and at times there is infection, there is swelling, and they are worried about it. Now I've recently written a paper on the management of congenital epiphora due to nasolacrimal duct obstruction, and it is in the process of publication. that it has been conventionally taught in the past that do massage, put drops, do massage, and this is the method of massage, this is the method. I've proved with this study that the massage is not required. Auto canalization is a rule, and if it has to be there, it has to be there. So massage, unnecessary handling of the eye with the finger, which may not be clean, can lead to infection, roughening of the skin, injury to the very soft tissues. It's better to just convince the parents and give some antibiotic drops if there is some infection and clean it. It will auto-canalize in 6 to 8 months time by itself. It's a congenital nasolacrimal duct obstruction. I've discussed this thing. Now, inflammation of the lacrimal sac could be acute or chronic, and it is a feature that we see in adult in our outdoor. In acute, there could be pain, redness, swelling in the corner of the eye, जैसा कि उस बच्चे में था, and in the corresponding area. And treatment is systemic or local antibiotic, cleaning, regurgitation, regurging of pus, cleaning of the pus. And once the condition is settled, the treatment is DCR. In this process, a channel is made between the sac and the nose by removing the membranes and the bone. There's no need to go into the detail. There's no need to go into the lacrimal gland tumor. 50% are epithelial tumor. Out of these 50%, 25% is benign and 25% malignant. You can see a small swelling here. What is the commonest cause of lacrimal gland in adult? Viral infection, mumps, viral infection. Now, lymphoid lesion, which accounts for another 50%, lymphoma, benign hyperplasia, pseudotumor, and some other difficult name here. You can see a large tumor in this area. And thank you very much for listening. Sure.